I'm going to invite the speakers. In the meantime, I will send the introductory slides for you. Now, yeah, Dr. Rajagopal Sridhar is the Associate Professor, Program Director, Fellowship, Pulmonary Critical Care Medicine and Sleep Medicine, SA School of Medicine, Director of Bronchoscopy, Medical Director, Respiratory. There's some hiding. Questions are hiding. Respiratory Care Program, Lincoln Land College, Illinois. When questions come, it upset. Dr. Vidya Sundaresan, Professor and Chief Program Director of Fellowship, Infectious Disease, SIU School of Medicine, Medical Advisor, Local Health Department, Governor ACP, Illinois South. And Dr. Didar Singh, MD, FACP, Hospitalist, Springfield Clinic, Illinois. And Dr. Rajshekhar, all of you know, he'll be joining us soon. So now I'll stop sharing and I request Dr. Vidya, who is a very, very enterprising clinician, an infection disease specialist. Her lovely husband is Dr. Rajagopal Sridhar, Raj Sridhar. A very ideal combination, especially this COVID time. An infection specialist marrying a pulmonologist, very, very rare here in this part of country, but they are doing wonderful work. Along with it, Dr. Didar Singh, who is a hospitalist, is also going to be with us. They are going to mainly cover, I requested them to cover three things. One is about COVID updates, including vaccines, the treatment as well as vaccines. The second most important thing which I requested Raj Sridhar is for oxygen, because now everywhere there is oxygen scarcity. And how, with the limited resources, how we can control this situation. What's the role of oxygen concentrators? Because a lot of oxygen concentrators are now in the market. So we would like to hear from Raj Sridhar about that. And the third one, when you are in a home quarantine, how do you do telemonitoring? Because most of our patients now may not require hospitalization. Because of the anxiety, everybody gets admitted into hospital. So who has to be admitted to the hospital? Who requires oxygen? Who requires steroid? Who requires heparin? All those details, Vidya and team will enlighten us. And you can always post all your questions. And if this is going to be a successful program, Dr. Vidya was kind enough to have a part 2 of this program a little later also. So whatever we can cover in this time, we'll cover. And I thank the speakers. You know, the time there in Chicago is early morning, 6 o'clock. So they'll finish our talk and then they'll go for their work. So thank you very much, Vidya, Rajagopal, Sridhar and Didar Singh ji for your commitment and your passion for teaching. Really amazing. And Vidya has done a lot of work, lot of webinars in this last 1 year on COVID and vaccines. So she's an authority in infectious disease and COVID updates. And Rajagopal, a leading pulmonologist, and Didar Singh, they are going to enlighten us and share their knowledge. So please feel free to ask questions, any question for that matter, even if it is simple and ordinary questions, they don't mind. So with this, I have great pleasure in requesting Dr. Vidya to take over and conduct the proceedings. Please, Vidya.
First of all, good evening to all of you, and thank you, Dr. Muruganathan, for this honor for us to present today to this esteemed audience. And we are really heartbroken with what is going on in India, and extend our support and whatever we can do to help in this situation. So please feel our support there for you. It's a difficult time for everybody, and we're really with you in this endeavor. To start out, we are three physicians currently practicing in Springfield, Illinois. Springfield is the capital city of Illinois. You know where Chicago is. And Chicago, this is about 200 miles south of Chicago. And it's a small place, but we did feel the whole pinch of COVID when it was at its peak in the United States. With vaccination efforts, it's come down definitely. And we do want to share some of the insights and some of our experience from managing COVID patients here. So just to begin with some perspective, in the United States, the total number of cases is about 32.6 million. The deaths in the United States were about 579,000. I put in parentheses what the daily mortality is now. So you can see that it has come down tremendously. We are also tracking the new cases per day. It was very high, and it's tracking down now. This is, in fact, still high, 46,000 new cases, but relatively come down quite a lot.
Vidya, sorry, can you make it a full screen, the slides? Can you go on slide presentation? Yeah, that's fine. That's good. Nice.
Thank you. So these are the numbers nationally in United States. In the state of Illinois, you can see that the total cases reported are 1.335 million, and the deaths here were about 24,000. Still high, and daily deaths now are come down to about 33. New cases about 2,572. We have plateaued at this number now. And what is the reason for that? In addition to the public health mitigation, in addition to management of patients, in addition to antiviral use, in addition to monoclonal antibody use, all the pharmacological measures as well as the non-pharmacological measures, which is essentially the public health measures. Also, the biggest thing is vaccination. So the vaccination efforts were extremely robust. So you can see nationally, people who have received at least one dose of the vaccine, 45%, and fully vaccinated about 32%. And in the state of Illinois, it is around the same. In fact, our county, in Springfield, you'll see about 50% of the population has at least received, in fact, fully vaccinated. Almost fully vaccinated is 50%. So that makes a big difference. This is what our curves look like. It was not very high, but you can see that in April of last year, March, April of last year, when the numbers were rising nationally in United States, in the state of Illinois, we felt that too. And it was hard to predict how big this curve was going to be, how big the surge is going to be, but it got mitigated, and this time mainly with the public health measures that were in place. People were following the three W's, which we still talk about: wear your mask, watch your distance, and wash your hands. 3 W's. Those were really followed in a good way, which helped flatten the curve. So the task there was to avoid the surge and to flatten the curve. I'm sorry. um, then the public health mitigation strategies and reopening slowly started in July, August. We felt all right. We have kind of gotten over that curve, and then you start seeing once the reopening occurred, although it was really phased and very careful. Here, there was this pandemic fatigue setting in about September, October. And that's really the time where, a lot of social events are occurring as well. This is right before Christmas, Halloween, Thanksgiving. That's really the time where a lot of people are getting together and in larger groups, a lot of social events happening, a lot of gatherings happening. And we saw that the curve just went up exponentially. What we were preparing for in April was nothing as compared to what we saw in end of October and November. And then this curve started to come down thanks to the vaccination. So in mid-December, the vaccines were available here. And then you can see that the curve actually came down beautifully. In March, we almost hit a nadir. And now, with the advent of variants and the vaccination efforts slowing down a little bit, we are right at that plateau. So it's gone up a little bit now, and we're right at the plateau. So we're accelerating all the vaccination efforts along with continuing what we are doing. And also, in terms of reopening, the phased reopening is considered again. So that's the epidemiological curve. Although a small place, you will see that the patterns have typically been the same. So, first wave, second wave, and then a potential third wave here averted, almost with those robust vaccination efforts. Metrics which are followed very, very carefully, and these kind of help uh, us gain some insight into what's going to happen. So you look at the new cases per 100,000. For our small town here, our limit there is supposed to be 50. We are at 183. So we were still given an orange status. Blue is good. We were still given an orange status saying that's a warning status. You need to try and get this number lower down. And we were also tracking something called percentage positivity. And when you check a percentage positivity, this is the test positivity for that particular day. One day's test may not be valid. So you also look at a 3-day rolling average, a 7-day rolling average, because the tests may not come back at the same day too. So 3.2% for a percentage positivity now, 7-day rolling average was 3.5. It's fairly low. Our target here is 8%. You want to be less than 8. Anytime it goes above 8, the mitigation efforts are tightened a little bit. Right now, I'm reading, and the sources are some of the American media, this number that has been reported, a percentage positivity in India is upwards of 30% or even 40% in some places. So you can imagine how high that is as compared to what the targets were set for Illinois. CLI is COVID-like illness in the ER and COVID-like illness admitted to the hospitals. This could be anything, because at this point you're not sure. So they termed this as COVID-like illness in the ED emergency room, and those that are admitted. You want to track that. You want to see if that's stable or decreasing. That's another metric which is followed very carefully. You look at clusters of cases. This gives an idea of outbreaks that are occurring, and youth cases. These help us also determine whether it's safe to reopen schools or not. If the youth cases are higher than what you would like them to be, then in that case, the mitigation strategies are targeted and looked at to see where they can be tightened. And this is something that is tracked all along, helps the hospitals, helps the healthcare system. The biggest thing with COVID, what's happening in the community mimics what's happening in the hospitals. And the hospital not to overwhelm them, the healthcare system not to overwhelm them, just to ensure that everybody is able to get the care that they deserve, has been one of the goals. And this metric is something that they track, and this allows them to ensure that there is enough resources in terms of manpower and in terms of equipment, in terms of medications, whatever resources are needed to take good care of the patient, that's available. And ICU bed availability is tracked. So you want at least 20% beds available. And this is for COVID and non-COVID patients. This allows us to understand whether the healthcare system is overwhelmed or not. So at this time in our area, we are at 23%. We're slightly above that mark, but they put us in warning status because it's so close to 20%. So you'll see that even though the numbers are not very high, they give you these goals, so you can track and see even before the crisis sets in, you're able to intervene. And of course, mortality, tracking mortality, that's trended. You want that trend to be decreasing. This is another thing that is tracked. They also look at which place is the maximum exposure. Right now, with the vaccine efforts, you're seeing that what used to be a big chunk of this pie chart was nursing homes, or when I say nursing homes here, it is assisted living and places where elderly patients are in fact housed. So those congregate settings were, in fact, a big chunk of that pie. But now, with vaccination efforts, really robust vaccination efforts in all those areas, you saw that particular exposure by location came down significantly. And what we are seeing is now schools, because they've started to reopen schools, and also this particular age group is not yet vaccinated. So again, goes in favor to say that vaccination is really effective. And then the other areas which are also tracked. So I just wanted to give an idea of how things are being managed here and what is being tracked. And with that, I will hand it over to Dr. Didar Singh. This was from a public health perspective. Now we are going to go straight to Dr. Didar Singh's talk about home management of COVID and in-house care when a patient is admitted with moderate disease. What is mild disease? What is moderate disease? Dr. Didar Singh will tell us about that.
Hello, everybody. Thanks, Vidya. Hi, everybody. This is Dr. Didar Singh. So I'm a practicing hospitalist in Springfield, Illinois. So I've been managing COVID cases since the onset of this pandemic. And I usually take care of the hospitalized patients. So in that setting, I'll be able to talk with my personal experience. So when we see a COVID case, it's classified into mild disease, moderate disease, and severe disease. Mild disease will be defined as somebody who has a low-grade fever, cough, sore throat, but no shortness of breath. So once they start developing shortness of breath, then that puts them in the category of moderate disease. In that case, we have to be very cautious and have to be careful that at what point they would need hospitalized care. If they start developing desaturation, when the oxygen saturation drops below 94%, or their breathing rate is more than 24 per minute, or they have unstable hemodynamics, then we have to be very cautious and early hospitalization will be warranted. So very close monitoring in a home setting will be needed for these people to get admitted before they become too unwell. So patients who will be appropriate for outpatient treatment will be who doesn't have any shortness of breath or their saturation is more than 94%. We have to be careful about the patients with the risk factors along with COVID who would need very cautious monitoring. And those typical risk factors will be somebody with chronic diseases like COPD, congestive heart failure, diabetes, or other underlying chronic lung diseases, or immunocompromised state. So there is some data in outpatients with mild to moderate disease who benefit from monoclonal antibodies, which Dr. Sundaresan and her team have been using here in Illinois, which is found to be effective in preventing hospitalizations. But the key is that you have to start identifying these patients early, and if they are given within 3 days, then we can prevent a lot of hospitalizations. In the home setting, patient should be able to, or somebody around them should be able to monitor for signs of worsening in terms of shortness of breath, unstable blood pressure, change in mental status, be able to monitor oxygen saturation at home. So they should be able to pick up these things early on so that they can advise appropriate care, which would be inpatient care. So in inpatient care, we make quick evaluations about the clinical status of the patient based on how much shortness of breath or discomfort they're having, monitor their oxygen saturations. So we here in our practice have been using steroids for anybody who is requiring supplemental oxygen or their oxygen saturation is less than 94% on room air. So we use dexamethasone 6 milligrams once daily for at least 10 days or whenever they're fit for discharge, whichever is early. Alongside, we have also been using remdesivir in these patients in the dose of 200 milligram once daily on the first day, followed by 100 milligram. There is also role of convalescent COVID plasma, but the key again is to use it early in the disease within 72 hours. Then it's been shown to prevent the progression and the severity of the disease. Although there are some conflicting reports about COVID plasma in the literature, but again, the key is to use it appropriately in the early window where it really helps in halting the progression of the disease. With that, the role of anticoagulation, we have routinely been using in hospitalized patients the prophylactic anticoagulation with enoxaparin or heparin. Certain patients who are considered at relatively high risk, which will be defined by a BMI of more than 35. I've been using enoxaparin 40 milligrams subcutaneous BID. It's very, very important to keep a high index of suspicion for thrombotic events in COVID patients. It's a highly thrombogenic disease. We have seen several patients with DVT, pulmonary embolism. I have also seen a patient who was actually on apixaban on date, and he was in the hospital. While on apixaban, this patient developed a saddle PE. We were able to recognize that quickly and salvage the patient. So you have to keep a very high index of suspicion for thrombotic events. That is where the role of CT scan comes. So we have been using CT scan only where we are suspecting a pulmonary embolism. Otherwise, role of CT in routine patients who are hospitalized is not great. And we have been hearing reports like in India, everybody gets HRCT, which is probably not warranted. It leads to unnecessary anxiety and exposure to radiation. As HRCT, it is equivalent to about 200 to 300 X-rays. Then in outpatients, routine anticoagulation is not recommended. There is more risk of bleeding in outpatients with routine anticoagulation. Same for the hospitalized patients. At the time of discharge, we do not routinely recommend any anticoagulation upon discharge unless they qualify because they had a BTE event. Regarding steroids, so they're not recommended for routine use in outpatient in patients with the mild disease. So another aspect we have dealt is basically telehealth in hospitalized patients, where we were trying to avoid exposure before the vaccination was available. At that point, we were able to interview the patient via an iPad, and that was actually very helpful when the vaccine was not available. Lately, we have not been dealing much with telehealth with these devices. We feel more confident, and we have been trying to provide a personal touch by going in the room and using proper protection with PPE kits and all. So early on there was a role, but at this point I think we are more confident as all of us are vaccinated, and it has really been challenging to take care of these patients early in the disease. At this point, we have more data and we have more confidence. Yes, Vidya.
Thank you, Didar. Dr. Raj, would you like to share your slides, please?
Can you hear me? Sorry.
I can hear you, yes.
Yeah. So I quickly went through this. Thank you for the opportunity for inviting me for this presentation. It's been a great pleasure, and I really don't have any financial disclosures. So I always remember this saying in the Bhagavad Gita, which says, breath is the bridge which connects life to consciousness, which unites our body to our thoughts. So whenever the mind becomes scattered, you use your breath as a means of an anchor to take hold of your mind again. So this is a very important saying which the chapter 1 of the Bhagavad Gita begins. So it's a very this situation in India and around the world, this makes a lot more sense, and because it's a really personal thing for all of us at this time. So I'm not going to talk to you more about the oxygen. I'm just going to talk to you some of the basics about oxygen therapy. So I'll talk about oxygen concentrators, compressed gas cylinders, liquid oxygen. How can we conserve oxygen in which the demand is so high, and what about high oxygen delivery systems? So remember, oxygens concentrator basically are the preferred means for delivering home oxygen in a continuous fashion. It works by concentrating the oxygen from the ambient air. So we're breathing 21% oxygen, and majority of the time we are breathing nitrogen actually. So when we talk about oxygen concentrator, what it talks about is taking away the nitrogen from the air. So there are two types. I mean, you have the low capacity systems, which go from 0.5 liters to 5 liters per minute on the right side here. And they are typically for patients who have COPD or pulmonary fibrosis for home therapy, but can also be used for COVID patients. The higher ones are not as portable. They have wheels, and they can go up to 15 liters per minute, and they cause high flow concentrators. The advantage of concentrators are, number one, they do not need to be refilled, unlike tanks. You can have higher flows of 15 liters per minute, and the oxygen source is unlimited because as long as you have air around you, oxygen is available. The disadvantages, again, it needs a continuous power source. I mean, you cannot have power fluctuations also. You need like 300 watts of power or 240 volts of continuous power. And there's a little bit of a delay. Like when you start the machine, it takes roughly around 5 minutes for the whole concentrator thing to start working. And, so that's one thing. The filter is also got an oxygen filter, which needs to be cleaned routinely. And if it's not, it can block and the whole system kind of does not work as it should. It can be pretty noisy also. So what about oxygen tanks? Well, oxygen tanks are basically compressed gas. It comes in different sizes. You have the small ones, which weigh around 3 kilograms and provide around 430 liters of oxygen. You have the bigger ones, which give up to 2,000 and up to 4,000 liters of oxygen. But remember, this may sound a lot, but if a patient is breathing using oxygen at 3 liters per minute, this typically lasts for only 2.5 hours. So it's only for a limited amount of time. It's a finite source. It comes in different sizes. It's got a flow regulator. It's got a pressure gauge, which needs to be monitored because as the as the oxygen pressure decreases, this dial moves to the left, and that needs to be monitored. And this is the flow gauge, how much oxygen the patient is actually getting. It's also has got a safety valve, which shuts off when the tube gets disconnected. So this is something which can be used for transportation. It's very portable. The biggest advantage is it can be used without power. I mean, and it's very cheap, except for the steel tanks, which can be recycled. The oxygen itself and maintenance is very cheap. The problem is it's a finite source. It does not last too long. It only lasts for around 2 to 3 hours. It is a fire hazard because it's compressed oxygen, and each time oxygen is pressurized, there's a risk for fire and explosion. So it has to be very carefully. Safety is very important for these tanks. It needs frequent filling by the oxygen company. So typically, it's not very useful except for in ambulances or transport. Cannot really rely on oxygen tanks for long-term supply. So how do we solve this problem? So that came in the 1980s and 1990s. Oxygen started becoming, demand went up. More people were on oxygen because of chronic health conditions. So oxygen companies started researching on liquid oxygen, which is basically oxygen which is pressurized and frozen to a temperature of minus 183 degrees. So each time the oxygen gas is cooled, it contracts. So the expansion ratio is 860 to 1. That means 1 liter of liquid oxygen when evaporated, provides roughly 860 liters of gaseous oxygen. So it's a lot. So the only disadvantage, of course, is it must be vaporized. So the liquid gas has to be converted to vapor, the regular gas. So it requires a special equipment to do that. But again, gives you the most bang for your buck. So typically for home patients, you have this big oxygen, we call it the mother liquid oxygen tank. And these are the portable tanks they can carry. You can see that it's got a special device around this, which will convert the liquid form to the gas form. Now, most of the hospitals and most of the plants use liquid oxygen because you take the air, you compress it, you filter the air, then then the air is cooled. Each boiling points for liquid, for oxygen and nitrogen is different. So once the oxygen is cooled, it's stored into this giant tank through which it can it can be repressurized, so you can increase the pressure to even higher grades. And that is something which can be, and that can be collected in different tanks. So a lot of the hospitals and nursing homes in the US and around the world use this system because it lasts much longer. So the advantage is, again, longer oxygen supply. You don't need to replenish the oxygen. Remember the ratio, it's around 850s to 1 ratio. So 1 liter of liquid oxygen can give you 850 liters of gaseous oxygen, which is a big, which is very large amount and it'll last for a longer period of time. You can also go to a higher flow systems, and liquid oxygen you can go up to almost 15 to 20 liters per minute, which is useful especially in hospitalized patients. The disadvantages is the cost and maintenance. So a lot of these things, either you need to have an oxygen plant at the hospital, or you need to have a constant supply of this material from oxygen company. It's also hazardous. I mean, there was a big fire in Maharashtra, Nasik. I think they had almost like 30 people were killed because they were not maintaining this safety standards. So it's a big hazard, and this is a problem all around the world. It can also cause icing. So each time you turn the liquid oxygen to gas, the water vapor around can condense, and that can break the valve on the cylinder, and that can cause increased risk for explosions and fire hazards. So before I go further, I would like you all to know about this concept called peak inspiratory flow rate. So, for example, when you're sitting at rest and you're breathing normally, let's say your tidal volume is around 500 ml, that is half a liter, and you're breathing at 15 breaths per minute. So again, remember that minute ventilation is tidal volume times your respiratory rate. So the minute ventilation for most people is between 6 to 8 liters per minute. Now, typically, if you're breathing normally, each breath takes about 4 seconds. That means inspiration takes about, because the inspiration to expiration ratio is 1:3. So you spend around 1 second for inspiration. It's an active, high flow process. Expiration is a slower process. It takes 3 seconds. It's a passive process. So, for example, if you have somebody who is breathing at normal breathing, 500 ml, and that means every 1 second, you take a breath. So the flow rate is 500 times 60, which amounts to 30 liters per minute. But remember, if you have somebody who's dyspneic or if they're tachypneic, their inspiratory flow rates are much, much higher. So they may be up to 30 liters per minute, so up to from 80 liters per minute. So that's an important concept to keep in mind when giving oxygen therapy to patients, because remember, low flow systems, are unable to match the patient's demand. So if you put somebody on a nasal cannula and they're breathing 30 times a minute, they may not be getting enough oxygen because their oxygen, what they're getting, is being diluted by the ambient air. So the actual oxygen concentration at the alveolar level can be much lower than what the patient is actually getting, is because of dilution by nitrogen if the patient is tachypneic. So it's very important to remember this concept. So not only turning up the oxygen is important, if the patient is short of breath, you might need to look at other systems in such patients. So when you talk about oxygen delivery system, you have the low flow system in which use a nasal cannula. But remember, if the patient is tachypneic, they won't be breathing through the nose; they'll be breathing through the mouth. So a lot of other, the ambient air is going to come and dilute the oxygen they're getting. One simple solution you can try is using the Hudson face mask. It's got the oxygen source. It kind of fills the mask with oxygen, and it kind of gives you a higher level of FiO2 for this patient. It's got side exhalation ports for carbon dioxide. So this might help in such patients who are tachypneic and hypoxic. The other solution you can also use is in a low flow system. That means the patient is in an oxygen concentrator, or and you're in a supply system in which the flow is around 10 to 15 liters per minute. You can use Hudson bag. It's like it's a reservoir bag. So same concept as a simple Hudson mask, but now you have a one-way valve here. So the oxygen comes in here and fills this bag with 100% oxygen. And when the patient takes a breath or is breathing fast, this oxygen, the valve opens and gives them extra oxygen. So in a way, it prevents dilution of this oxygen with nitrogen from the ambient air. So that is one concept we can use. You can also add little ports, flaps on the side here. That is for preventing, we call it non-rebreathers. So that means you don't rebreathe your own air. So you don't rebreathe your own carbon dioxide. So that's one way to do it. So this is something you can also have. Again, this system is a little bit more expensive, but especially because the valve is more expensive. So, but again, if it's available, that's one way to do and to conserve oxygen. Let me talk about how do you conserve oxygen. So before I talk about high flow system, again, oxygen conservation is very important. So what are the strategies we can use? First of all, you really want to, when you look at the pulse ox, or you send home a patient with the pulse oximeter, be sure when they read the pulse oximeter, they should read for at least 30 seconds. They should have a pulse, the pulse should be beeping and lighting up, and then the oxygen should be read. A lot of times, if it's not properly placed and there's no pulse with the oxygen, that reading is inaccurate. So a lot of times I get calls from my patients, hey, my oxygen level is 75%. I said, did you put it on properly? Are you checking, is it syncing with your pulse? Be sure that you talk to the patient about that. And second thing is, not all patients require, SATs more than 95%. That means, you don't want to. So typically I target my patients between around 90 to 94% of oxygen. And the higher does not mean better. More oxygen you give, there's a high risk for oxygen free radical formation and secondary lung injury. So you want to avoid that. So have a conservative oxygen strategy. Be sure they're measuring their pulse ox correctly. If you're not really convinced about their technique, it may be reasonable to get an ABG, arterial blood gas, to see their, what is their acid-base status, how much carbon dioxide they have, what is the PaO2 of this patient. So that's reasonable to do that if you are kind of concerned about, actually how was their oxygen, partial pressure of oxygen. You can also use other devices called oxymizers. I'll talk about it in the next slide, and that can also help, conserving oxygen. You can switch the use of liquid from gaseous oxygen to liquid. Again, the higher compression ratios, they can be, you can use that if it's available. Typically, I recommend putting a mask. So anybody is wearing a cannula, just using a simple face mask, like a surgical face mask, can help reduce loss of oxygen. And also kind of prevents infection too. So I'll have some of my patients wear oxygen mask over their oxygen by nasal cannula. You can also use, if it's a humidified oxygen system, and sterile water is short supply, you can use distilled water. That can also, conserve oxygen. Using a distilled water system, not only humidifies it, you can actually conserve oxygen. And let's say in a situation where they have a lot of patients in the emergency room, you can use a Y connector. So Y connectors, and two people can use from one source of oxygen using this Y connector, and that's just another way of doing it. Always be sure every day to be sure that there's no leak in the machines. And that's something which leak is a very common problem. Icing is a common problem, so be sure they check their machines, or you have somebody check the machines. Combining the use of non-invasive ventilation or using CPAP with oxygen can also help decrease the need for oxygen. So combining CPAP, let's say at 10 centimeters water pressure, you're able to cut down the need for FiO2 by almost 30% in these patients. So when I talk about other devices, I'm talking about devices like this. Looks like a mustache or like a pendant. These are called oxymizers. You can also have the patient self-prone, have them kind of lay on their belly. That can also improve in not only lung recruitment, but also decrease the need for oxygen. And So how does it work? Well, this is a reservoir. It's called a pendant. Oxygen comes through here. It's kind of stored here, and that kind of releases through when the patient inspires. You can also use this. It's called a mustache model, in which it's like a little faceplate. And here, basically, what happens is the oxygen helps also in when the patient exhales. Not all the oxygen, as we know, is absorbed. Some of it is also stored here. So if you look at this, if you use such oxygen devices, let's say, for example, the patient is on 5 liters of oxygen. If you use any of these devices, you can now almost cut down the need for the oxygen by 50%. So with the oxidizer, you might need actually 2.5 liters to maintain the same level of saturations. So, but remember, as the flow goes up, the efficacy also goes down. So, so be aware of that. So I add this picture all the time of Ravana, a very very intriguing character to me, but because of his big mustache. So each time I talk about this talk, I always put this picture, and all the Americans in the US are very fascinated by this. So I know they all smile, and other thing you can also have patients do is combining stuff. Like, for example, you can self-prone the patient. They can self-prone as well as using such devices, and you may be able to turn down the oxygen flow. So prone positioning is very important, as you know. Typically, it was done in hospitalized patient with ERDS. So they're intubated, they're paralyzed. So basically, they have their arms up on their side, or they have their arms on one side. It's called swimmer's position, and you kind of change these positions, or the nurse changes this position every hour. So to prevent skin breakdown and myopathy and stress ulcers and things like that on the body. It does improve the chest wall compliance. It all, remember, the posterior 1/3 of the posterior part of the lung, when they are supine, does not really participate much in ventilation. But when you prone them, you have increased surface area, you have more ventilation perfusion matching, you increase the diffusion capacity. So that improves gas exchange. So I strongly recommend doing that. It also prevents progression of pulmonary inflammation. It also has been shown to decrease mortality, especially in intubated patients with severe ARDS. So from the ProSiva trial, so we found out that actually improves mortality. Awake proning is also very important for patients, can be done for patients who have at home. You can do that. It's a low risk. You can educate them how to do that. Basically, you can have them self-prone at home, change their positions, at home every 2 hours, lay on their belly for half an hour, lay on their left side for half an hour, lay on the right side for half an hour, lay on their back for half an hour, so they can rotate this cycle as long as a self-monitoring. So this has been shown to be useful not only in decrease the need for oxygen, it also has been shown to prevent progression to severe form of COVID pneumonia. So let's change gears and talk about oxygen delivery system, which require high flow. What does that mean? High flow means they have the ability to match or exceed the patient's peak inspiratory flow rate. So if they're very tachypneic, they're having very high ventilation, they can compensate for that because it guarantees the set oxygen going to the patient. It's able to provide very high FiO2. Again, and also provides heat and moisture and humidity to prevent the drying effect of dry oxygen. So that's a big advantage. The two systems available, one is a Venturi mask. Venturi mask is basically a little port, like a jet-like port. And basically what it does is you can change the orifice or the diameter of this port. So the smaller the orifice, so here basically gas is coming in, you can adjust the diameter of this. So it acts like a jet, So that helps in getting more flow to the patient. Now, you can also change the diameter of the hole. So, and if you change the diameter of the hole, you can change how much FiO2 they're getting. So smaller the gas orifice, the more the velocity, the more the pressure. They have less entrainment or less, dilution of the ambient air. And again, they get higher FiO2. So if you open the Venturi port, it causes more entrainment of room air and lowers the FiO2. So typically comes, for example, here is wide open, the Venturi port. So it kind of sucks in more oxygen, it sucks in more air and thus diluting the oxygen in a sense the patient is only getting 24% of FiO2. But now as the hole goes down, diameter goes down, you're getting more FiO2 because there's less entrainment. And typically venturi masks are combined with a full face mask. So in that way, it will prevent further dilution of oxygen. So I'm not going to go through the physiology of it, but again, it's a very venturi effect is one of the well documented and well studied effect in pulmonary physiology. So other system is a high flow nasal cannula. This is again, we had not used this very often till recently. Now almost all patients are with moderate to severe COVID are on this we call it OptiFlow or a high flow nasal cannula system. It's got a flow meter and a pressurizer. This requires a lot of oxygen, so you really require up to 40 to 60 liters per minute of oxygen flow. So it's very high flow. Oxygen flows in through here. There's a blender, and it is also a humidifier. And this is the one in which the air oxygen is humidified, pressurized, and sent through this heated inspiratory circuit to the patient's nasal cannula. It provides up to 60 liters per minute of oxygen at almost 100%, FiO2. So it's a very high flow system. Consumes a lot of oxygen though. So if you are on a situation like when the oxygen is deficient, this may not be very helpful because you consume 60 liters per minute of oxygen. So this is how it looks like. It comes it's got a little wheel, humidity there. This connects to the wall, and that goes to the patient. So when would you use this? Again, this is the kind of the paradigm model I tell all my students, always remember your physiology. Physiology will save a patient. So always go back to basics. I read more on physiology than I read about medicine actually nowadays because it's so fascinating and things are changing. So each time you talk about oxygen, you really need to know physiology. So how does this work? Again, you have heated humidification and inhaled gases, which improves the secretion clearance, improves bronchoconstriction if there's any. You decrease dead space. You fill the upper airway with fresh oxygen. You decrease the nasal resistance. You help recruit atelectatic lung segments, which again improves and decreases stress and decreases lung compliance in these patients. Improves actually the inspired oxygen, because right now, remember, using high flow system, so you're not diluting the air, the oxygen you're breathing in, because you're breathing in 100% oxygen. So that's very important. It does improve comfort. It has been shown to prevent the need for intubation, mechanical ventilation in this population of patients. So this is the typical. This came from the thorax last year during the COVID pandemic. Again, the patient comes in hypoxic. Again, check the SATs. If they're above 92%, I think you're okay. If they're below 92%, you can be even more conservative and say less than 90% if you want. And they're short of breath, you can try regular oxygen. This patient is already on oxygen. Let's say they're decompensating. You might want to try, if it's available, a short the trial of high flow oxygen. This setting 30 to 60 minutes at 6 liters per minute, FiO2 100%. See if they if they're maintaining it. But again, if they're not, or they become more tachypnic, they become more short of breath, they have more symptoms, they develop altered mental status, then they might need to be intubated, or you might want to try for a short time non-invasive ventilation like bilevel PAP therapy, and again, closely monitoring these patients. So I'm not going to go through much details, but again, I think my thoughts on oxygen, I just want you to see this slide. This was a roll up of our patients who came with mild COVID to the hospital. He was only on 2 liters per minute. You can see the peripheral infiltrates here. By evening time, he kind of progressed. He had a history of heart disease with a pacemaker. Again, more infiltrates. And by next day, like around 5 o'clock, again, further decompensated. He ended up being intubated, became again hypotensive, developed complete cardiovascular collapse. This is swan gas, it's a diffuse white out of both lungs. So what we also have been doing more often is in India, there's a tendency to get a lot of CAT scans done. We hardly do that. Initial CAT scan may be done, but if the patient's X-ray is looking like this, you got to look at the patient first before doing a CAT scan. We do a lot of lung ultrasound, and it's almost like every other shift we do the bedside lung ultrasound. So here in this patient, you can see some scattered B lines for mild disease. But as the disease progresses,
You can see extensive B-line formation indicating severe consolidation and diffuse whiteout. It's cheap, and we don't charge the patients for ultrasound, but CAT scan is expensive, radiation exposure. So we just do daily or twice daily ultrasound for these patients. So I can stop here if anybody has any questions, or I can keep going.
Please keep going, sir.
Okay, sorry. Quickly, this is my perspective as an intensivist, as ICU doctor. So again, I think Dr. Didar Singh has spoke very well regarding at-home therapy, and yeah. So this is my perspective as an intensivist. I think the next 3 slides are on that. So I think Dr. Singh and Dr. Didar Singh talked very well about this, and hospitals do a lot more than we do on the regular wards. So in the ICUs, I think I can focus more on that. But again, the home therapy still works. I mean, every COVID positive patient does not need to be in the ICU. So, but the patient needs to have definite action plan. That's something we have to develop if they get worse. So in the US, we have certain, they know which number to call if there wasn't what to do. And, they are given their acid check their oxygen level through pulse oximetry, monitor their vital signs as, how many times they breathe, how they're feeling, their dyspnea scores. We always educate the patient regarding home self-proning and lung recruitment maneuvers. You can use like a flutter valve or an inflammatory spirometry for these patients. Earlier on, you can also try, therapy with monoclonal antibody infusion, such as, we call it BAM and ET. So a combination has been shown to be useful. Again, they need. When you also talk about action plan, we also need to set up if they can take oxygen at home if needed, if that can be arranged. That's very important. But a lot of time, if they're hypoxic, typically we admit the patients in the hospital. Typically, the steroids, in my opinion, is only for patients who are really hypoxic. If on oxygen, this is based on the recovery trial. Not much data for patients who are not on oxygen and their saturations. Oh, sorry. So yeah, sorry. So use of oxygen is recommended if they can get oxygen at home. It's part of the action plan. So let's say the oxygen level of the patient is less than 92%. Need to be sure that they're prescribed oxygen at home, or if they get worse, they need to have a pathway to come into the hospital and get treatment. You can also try infusion of monoclonal antibodies. These 2 medications, I can't even pronounce them, but bamlanivimab and etesevimab have been shown to be useful in preventing hospital admission in these patients. So this is from the Journal of Emergency Medicine. They talked about, for non-intubated awake proning. So basically, every 30 minutes they change. So we also give them instructions when they go home. This is what you need to do, and have their caregiver at home ensure they do that. So for in-hospital treatment, again, close monitoring. Sorry, you can't hear me?
Yeah. Now it's good. Yeah, it's better.
Okay, yeah. Sorry about that.
Yeah, it's better now.
Yeah, sorry. So for in-hospital treatment, again, very close monitoring of vital signs, labs, inflammatory markers like ferritin levels, CRP, D-dimer is recommended. We also do POC's point of care ultrasound of the lung. So, we as pulmonologists, we have this ultrasound machine, we carry and do it, twice a day for some of the patients or multiple times a day to see if their lung disease is progressing or not. Oxygen therapy, again, high flow, use of NOS or CPAP can be done at the floor level, use of dexamethasone. You can use IL-6 inhibitors like tocilizumab and serilimumab in combination with dexamethasone if they have significant increase in their inflammatory markers like ferritin and CRP. Antiviral therapy can be given. Remdesivir has been used, but I'm not sure how much benefit it is for patients with moderate to severe diseases. And same thing goes for convalescent plasma. What's the overall benefit? There's been mixed data. So I'm not against or for it, but I've not seen a very strong, effect with the plasma. DVT prophylaxis is recommended for all patients with COVID if they're hospitalized. There is no need for full dose anticoagulation unless they have DVT or PE documented. So you don't want to give them, before we used to anticoagulate all patients who have COVID in the hospital, but that increases the risk for bleeding and unnecessary complications. Well, so we typically give either low molecular weight heparin like enoxaparin or fondaparinol for these patients. You can also give NOACs for prophylaxis in these patients. But again, if the patient becomes more hypoxic, acutely hypoxic, and the X-ray has not changed or ultrasound has not changed of the lung, then think about PE in this patient, pulmonary embolism. So again, those patients may need anticoagulation with IV heparin drip or full dose subcutaneous enoxaparin, 1 milligram per kilogram twice a day. So that's for the thromboprophylaxis. For ICU care, I mean, this is one of our patients. Again, we typically start with high flow nasal cannula. We typically do a bedside ultrasound every 6 to 8 hours. And again, you also evaluate for barotrauma, lung trauma. Most of the patients, we get in ICU typically end up getting intubated, unfortunately. We also always use lung protective ventilator strategy. That means we use low tidal volumes, so 6 cc's per kilogram or 6 mLs per kilogram of the ideal body weight, along with higher PEEP, starting PEEP of between 10 to 15 centimeters of water pressure. That has shown to help. We always do bedside echocardiogram for these patients. We want to be sure the right ventricle is working well. Remember, in ARDS and COVID pneumonia, you have right ventricular failure. Sometimes, you can also see, PE, central PE with the use of echo. So typically, we also do bedside echocardiogram for ICU patients. Most of these patients are sedated, heavily sedated. They're paralyzed with, cisatracurium or vercuronium drips. Because each time you paralyze somebody, their muscles consume less oxygen. So your oxygen requirement goes down. They are more in sync with the ventilator, which helps with your oxygenation strategy. Typically, if they have sudden decrease in their oxygen levels, or let's say they're already on maximum oxygen therapy on the ventilator, we start anticoagulation because they're too unstable to do a CT scan, or we typically do Dopplers of their legs if they have edema or swelling, just to be sure there's no DVT. But all of them, of course, get DVT prophylaxis and possible proning and possible full dose if we suspect PE. Most of them also end up getting continuous dialysis, with or without absorbing filters. We use something called Oxidus. It's a system which filters out cytokines, which filters out. There's some strong data with the use in COVID patients. They use, I think, in Bombay, they used it in few patients. So we use that sort of mechanism. So it's a continuous system, 24 hours a day, they're getting dialysis. And again, the patient continues to decompensate. ECMO is the only option. But remember, there's no data to suggest ECMO works. I mean, I know the famous SBB was an ECMO, and the data so far for COVID has been very, very poor for ECMO, almost 80 to 90% mortality with ECMO. So really, at that point, you need to talk to the patient regarding palliative care or end-of-life care. So that's the last slide. Again, thank you to all of you for working so hard in such difficult conditions. As Swami Vivekananda says, you're all luminous beings giving light in such dark times. So dark times back in the day was under British rule. Now it is COVID. So again, thank you. Thank you so much.
Now, Dr. Vidya? Dr. Vidya, yes.
Yes. All right. So I think a lot of what I was going to touch upon has already been covered either by Dr. Singh or Dr. Sridhar. I'm just going to quickly show you a resource which is very...
Can you make a slide presentation, bigger slide screen?
Yes, sorry. So this is the resource which has been looked at, which is evidence based. It's coming from the Infectious Diseases Society of America. Talks of the guidelines on treatment and management of patients with COVID. Has done a lot of meta-analysis and even looked at randomized clinical trials, and a lot of their recommendations are based on the evidence from these studies. So I'm going to go over a few of them. With regards to the use of hydroxychloroquine, or some people initially were talking about hydroxychloroquine plus azithromycin. The data is strongly against that. So we do not recommend the use of hydroxychloroquine or the use of hydroxychloroquine plus azithromycin. There is also a HIV medication called lopinavir and ritonavir. Remember, this was all started when we did not know what works for COVID. So everything was being tried. In fact, even now, there are so many clinical trials that people are looking at with medications used for rheumatoid arthritis or cardiac failure and anti-senility drug. So many drugs that are being looked at to see what works. So this was earlier on in last year. They were also looking at this HIV drug called Kaletra, lopinavir and ritonavir, to see if that works, and there was no benefit of using that. So Infectious Diseases Society of America recommends against the use of this combination as well. Next is tocilizumab. This is an IL-6 inhibitor. Raj Sridhar alluded to this. So this was again from the recovery trial, and more data has actually come out, published recently in Lancet, where they looked at a 28-day mortality as one of the outcome measures, and they compared a group with tocilizumab versus a group without tocilizumab. And definitely this was a significant improvement in a 28-day mortality. Therefore, the recommendation now actually is to utilize this in patients who have elevated markers of systemic inflammation, and they are relatively sicker. So severe or critical COVID along with elevated markers. When I say elevated markers, they're looking at CRP of greater than 75 as a guide for use of tocilizumab. Remember to use this earlier on. If you're able to procure it sooner, that's really when you have a lot of benefit. In fact, there are patients who have received remdesivir and then are not doing well. Even in those situations, we have tried tocilizumab. One dose, in fact, can make a big difference. You can repeat the dose if that does not help. One more time, a second time, the dose can be repeated in 24 to 48 hours. And this was alluded to again in terms of convalescent plasma. This is really a plus minus situation because it depends on how much of antibody that plasma specimen really has. So a conditional recommendation of a low certainty of evidence was made against the use of convalescent plasma. In fact, even the beginning when we didn't really have a definitive antiviral therapy for COVID, before remdesivir was available, plasma was something with virology giving passive immunity or passive antibodies. Through plasma, these antibodies are given passively. So there was considered to be some benefit. When we didn't have anything, we gave plasma. We did see some patients improve, but it was not consistent. Again, it really depends on what the quality of plasma is. They're saying that if you want a good quality plasma, it has to come from somebody who's severely ill, somebody who's at home with COVID. Can be a plasma donor, but their quality of plasma with the level of antibody may not be as good as somebody that is critically ill. So because of all those caveats there, the general recommendation right now is against the use of COVID-19 convalescent plasma. And if you want to use it, if you don't have anything else but plasma is available, again, the recommendation, like Dr. Singh was saying, it's better to use these early rather than later on in the illness. And then also against the use of, regarding the use of remdesivir, it is better than giving no antiviral treatment. Use it early. And the duration of treatment, 5 days is enough for somebody that is not on mechanical ventilation and on supplemental oxygen alone. There was a lot of discussion about whether or not this is useful for people with severe COVID, somebody who's on ECMO. Is it worthwhile using it? We do in our institution, our guidelines, the institutional guidelines, we have now included ECMO. We have included people on mechanical ventilation, any kind of supplemental oxygen. For remdesivir, we are giving it to them. Earlier on, when remdesivir was not available much, at that time, we were really restricting it to people that were on mechanical ventilation or supplemental oxygen. We were not giving it to anybody on ECMO. So right now it is available in plenty. So we do give it to people who are admitted to the hospital on supplemental oxygen. Again, the hospitalists who are taking care of the patients do a quick assessment and check the boxes for the inclusion criteria for remdesivir, which is mainly a moderate disease on supplemental oxygen, which would be the best group for remdesivir. Another thing that we also look at is the time of symptom onset. So you want to give it again sooner as compared to later. So the cap there is 10 days. Beyond 10 days, there's really no point in giving remdesivir. If you want to give it, you want to give it within the 10 days. So again, this is pretty much what I was saying earlier, 5 days versus the 10 days, and remdesivir versus no antiviral treatment. Yes, that there is some benefit, but you don't need to give the full 10 days. 5 days is good enough in people who are on just supplemental oxygen and not mechanical ventilation. Monoclonal antibodies, I know that the Regeneron monoclonal antibodies, or the cocktail as it's called, has been approved now. That would be the perisivimab and the imdevimab. These are extremely useful. They were giving bamlanivimab alone here, but with the appearance of variants, that alone is not beneficial. But when you combine that with etesevimab, that it is beneficial. It actually, our experience has been really good. People who are over 65 with one risk factor, people over 55 with one or two risk factors, even younger patients we have given if they have risk factors such as obesity, hypertension. We consider those risk factors. Diabetes, those are also risk factors. Anybody who has a greater chance of debilitation with COVID, so hypertension, diabetes, and any immunocompromising condition, and in children with sickle cell and some of those conditions where they could deteriorate significantly. These patients were considered. When I'm saying children, it's between the ages of 12 and 18. It's not approved for anybody less than 12 years. So right now, I know that once this is approved, the question would be who might be best candidates. Greater than age 65, you're going to get a lot of benefit for keeping these patients from getting admitted to the hospital. So keeping patients out of the hospital, this is extremely useful. People who are greater than 55 with more than one risk factor, again, that group is also very, very useful. And if there's immunocompromising conditions under 55, so 30 to 55, there are any immunocompromising conditions, consider giving monoclonal antibody. But really, the people of advanced stage, there's definite benefit of giving this and preventing admission in those people. There's now also some recommendation for the use of this drug for rheumatoid arthritis. It's actually a JAK1, JAK2 inhibitor. So the use of baricitinib with remdesivir rather than remdesivir alone, there is some data on this. We are not using this in the hospital, but this did show up in the recommendations from Infectious Diseases Society of America. So I went ahead and included that in the slide. Ivermectin, again, the data is plus minus. There was a good meta-analysis. If you want to look at the details, I didn't include those here for the because of the time constraint. But please do look at that if you're interested. The society actually recommended against the use of ivermectin. We had a lot of debate here whether or not it should be included in the protocol for patients who are admitted with COVID. But the consensus has been not to use ivermectin. I know it is used a lot in India. It doesn't really, it's a harmless drug to use ivermectin, but it really does not benefit the patient per se from the data that is available in the meta-analysis that was looked at by the Infectious Diseases Society. I wanted to quickly talk about the tests which are available, nasopharyngeal, oropharyngeal, high sensitivity, high specificity, and then the nasal tests. You can get 15% false negatives with just the nasal test. A saliva test now available even for the general public. We were using saliva-based test. This is a PCR test. We were using this for a surveillance testing in people who are college going, so higher education, all the children who are in college, who are on campus, and the faculty and the staff that's attending higher education and in person and on the campus, they had to check their saliva 3 times a week. This was a surveillance test, but now this saliva-based testing is kind of being, it has gotten approval for a diagnostic potential. It's still used as a surveillance test, but with diagnostic potential. It is a PCR test, high sensitivity, high specificity. You can also pick up strains. So any variant strains, even for that saliva test is good. Home tests, beware, there are a lot of false positives with the home tests. So I just wanted to put that there. Serology testing, antibody testing. In this case, you have to really take this with a pinch of salt. Antibody testing, IgM, IgG, this virus actually, the IgG and IgM appear at the same time. Generally, you see IgM coming before IgG. So it's a little different. And if you want to check serologies, you want to check after 3 weeks for the appearance of IgG, which tells you that there's some natural immunity from that or natural infection-causing immunity as the IgG titers rise. Also to keep in mind, there are different types of antibody tests. There's a spike protein antibody, which tells you that after vaccination, the spike protein antibody, if you can check that specifically, IgG for the spike protein would be up. And if you're thinking of natural infection, you want to differentiate between whether this antibody is from the vaccination or infection, the nucleocapsid. The antibodies against nucleocapsid are more so for natural infection. And a combination of both can be in patients who have had infection, have been vaccinated. So you could see those. So it can be useful. I don't think in a crisis situation, checking antibodies is really going to be useful in the current crisis. But if you see that being used, interpreting those with care is definitely very important. Antigen testing, or you're also using molecular tests. So in these, remember, there is 1 or 2 steps for the reagents that are used for PCR, RT-PCR, which are not performed. So the sensitivity, you give a little bit of, you give up a little bit for the sensitivity if a molecular test or an antigen test is used. You can also have false negatives. So interpreting those is also, you need to keep that in mind. I'm going to quickly run through this. There are about 89 vaccines in different phases. So there's a lot that is being studied and being available. Different types of vaccines, mRNA vaccine, and then adenovirus-based vaccine, inactivated vaccine, and protein-based vaccine. These are the 4 categories. mRNA is what is available here in the United States. So that is just the small messenger RNA, which is encoded by lipid. The layers around that are all lipid layers, which is what is injected as part of the vaccine. And that starts the whole cascade. With the adenovirus, you see DNA as the genetic material. And instead of this lipid coat, here it's an adenoviral coat. An adenovirus can be from either a chimpanzee adenovirus, serotype 26, or you can have any other regular cold type adenovirus too. The nice thing about that is they don't really cause disease, but they make the genetic material a little bit more stable as compared to the lipid layers which you see with the mRNA. Inactivated virus, this is what you see with Covaxin. So it's a whole virion, which is actually an inactivated virus, and used with some adjuvants. In case of Covaxin, they're using aluminum as the adjuvant, and then protein, just protein particles as a viral subunit can also be used for vaccines. Mainly, the mechanism of action, the mRNA or the adenoviral vaccine, it enters the cell where the vaccination is given, and it's the antigen presenting cells are eventually produced with the spike protein, whichever genetic material is used, the spike protein expressing themselves on the surface of the cells. Antigen presenting cells start the cascade with the T cells and then recruiting the B cells. When the B cells are recruited, antibodies are available, and then killer T cells are recruited also to combat with the virus. There is memory also, so you will also see memory B cells, memory T cells, which are also part of the immunological phenomena with the vaccination here. So I just wanted to quickly talk about the clots that people worry about with AstraZeneca. The lower age groups, it has been seen, but the benefits of the vaccine is far more. That was studied with J&J, which is available in the United States. The numbers of people developing those serious the cerebral thrombosis or large vessel thrombosis was not very high. So the proportion was very low. So the pause on J&J that was put in place has now been released. We are using J&J, and even with AstraZeneca, I think the concern, the benefits far will outweigh the concerns there. With the variants, I know a lot of questions come up about Hyderabad variant, double mutant, triple mutant. There are going to be variants. That's just the way the viruses replicate. When they replicate, they are not perfect. So the process of replication enables the variants to appear. And are they of concern? Are they of interest? This is something that the Center for Disease Control has been looking at. Here in the United States, they're tracking these B117, the UK strain, B1351, which is the South African, 427, 429 Californian, P1 Brazilian, and now B1607 Indian, a variant, or the double mutant variant. That's another one that they will probably start tracking. They haven't reported that so far. So these are the variants of concern where they can actually cause significant clinical changes or epidemiological changes based on their transmissibility, and also with how the disease manifests, whether it's a milder disease or a severe disease. So those things are determined, and that's why the variants are important, and also how effective are the vaccines against these variants. I wanted to end with this study that CDC reported on vaccine effectiveness and how important vaccines are. This was studied with about 74 million doses that were given, and a real life effectiveness of the mRNA vaccines. Of the 74 million doses given, only 5,800 fully vaccinated people had COVID. And there was mortality. 74 people had mortality. 7% required hospitalization. So it just goes to tell you that these vaccines are really, really effective. And again, the real life data here with Pfizer, which was an mRNA vaccine, 95% effective. Moderna, 94% effective. And Johnson & Johnson, which they said 66% overall. Real life, you're getting about 72% efficacy with that. So I'll end there and turn it over to Dr. Muruganathan. Sorry, we went over in the didactic part, But I will turn it over to you for the rest of the program.
Yeah. Thank you very much for that excellent presentation by all the three, Didarji, Dr. Raj, and Vidya. You have covered almost all the points, but unfortunately for me, there are about nearly 60 questions. I don't know how I'll ask all those questions. And Raj was very kind enough that he answered many questions in the chat box itself. So I would like to introduce our panelists also. Dr. Vijayan, are you there? Vijayan?
Yes, sir. I'm there.
Vijayan is a neurologist. He's tackling COVID cases, especially neurological part of COVID in Coimbatore. Dr. Rajshekhar, are you there? Rajshekhar? Yeah. Okay, he's not there. So we'll start questions now. I will randomize the questions because Vijayan is there. In a case of multiple sclerosis, who is taking on the immunotherapy, do you advise any restriction in the vaccine, or if you go about what vaccine you advise?
I don't think that there will be any restrictions on vaccines, sir. But if at all you need to take a vaccine, it's better to take a killed vaccine rather than a live attenuated one.
Vidya, would you like to add anything on this or multiple sclerosis society in the world?
Yeah. So, doctor, this is a good question. This comes up a lot. Multiple sclerosis, of course, is a unique condition. But in general, people who are on immunosuppressive therapy, and that can be anything: high dose steroids, chemotherapy, people with HIV. Is the vaccine good for them? Vaccine is really good for everybody. Whoever is able to take the vaccine should take the vaccine. With multiple sclerosis specifically, we do not recommend holding the medication or altering the dose or the timing of the medication. Rituxan is probably the only immunosuppressant which you may have to hold. If somebody is taking very high dose steroids prior to taking the vaccine, we may have to have them hold. But other than that, any of the other rheumatological conditions where somebody is on a biologic medication for rheumatoid arthritis, most of them do not require any alteration with the timing. So whoever's prescribed those medications, it's best to check with them to see if whatever immunosuppressant medication they're on requires any dose adjustment or holding. But for most part, it's okay to take the vaccine. And these are inactivated vaccine, like Dr. Vijayan was saying. The COVID vaccines are not live vaccines, so that way we are safe. Anybody who's on immunosuppressants, we always worry about giving them live vaccines, but that's not of concern in COVID.
And somebody has got egg allergy, somebody has got penicillin allergy. What do you say?
So the vaccine, the products that we really worry about is polyethylene glycol for the mRNA vaccines, and likewise for J&J or AstraZeneca or Covaxin that's available. Some of the adjuvants that are used in Covaxin, if they've had any previous allergies, they just need to be watched more carefully. Anaphylaxis to any polysorbate compound is the only time where you want to be cautious. Otherwise, egg allergy, penicillin allergy, any other allergy is not a contraindication for receiving the vaccine. If there is any concern, you want to watch them in a controlled setting for 15 to 30 minutes after giving vaccination, if possible. But you may want to extend it. I know you're already watching for about 10 minutes. You may want to extend that a little bit. But really, anaphylaxis is the only contraindication, and 2 polyethylene sorbate compounds. Otherwise, any other allergy is not a contraindication.
Yeah, a person who was bitten by dogs, they taking rabies vaccine, and how often, how long afterwards he has to take COVID, or vice versa. When the COVID has been taken first dose, he was bitten by a dog after a week. Can he take the second dose as scheduled?
A great question. Very good question. There are multiple parts to this. When you're taking, let's say, a flu vaccine and COVID vaccine, or shingles vaccine and COVID vaccine, or 2 vaccines together, you should not take them together. Although this is not a live vaccine, for COVID, they're recommending waiting 14 days for any 2 vaccines when taken together. But I think the question here was rabies. So somebody has taken the first shot of COVID-19 vaccine, and then they've required a rabies shot plus probably also immunoglobulins. The immunoglobulins may neutralize some of the antibodies and some of the antigen that's even there in the vaccine. So you may not develop as robust of an antibody response with the first dose. But never mind, you have the second dose, which kind of makes up for that. So the second dose can be given. You may want to space that out a little bit. So about 4 weeks after the antibodies, rabies antibodies is given, if the second dose is given. If you're using AstraZeneca, they're even saying the outer limit is 12 weeks. You still get a good antibody response even after 12 weeks. So you can even space it out to 12 weeks to give the second dose or second part of the COVID vaccine. You'll still get a very good antibody response with that.
What is the safety of vaccine in the pregnancy and pre-conception?
So COVID is much worse than the antibody, the vaccine. So if somebody gets COVID in pregnancy, you can have devastating effects. So the data now, just from the American College of Obstetrics and Gynecology, CDC, everywhere there is enough safety data of COVID vaccines in pregnancy. And I would highly encourage to give these vaccines to people that are pregnant, because with COVID, you can have devastating effects on the fetus. So definitely recommend vaccinating pregnant women.
And what about antibodies? See, we have taken 2 vaccines. And how long after we have to check the antibody, if at all, what antibody test you are by?
We do not recommend checking antibodies also. Except people who are immunocompromised, people with cancer, the oncology groups like to check. They want to make sure that they've had enough vaccine. In fact, the vaccine breakthrough infections that you're seeing a lot of people who are immunocompromised and do not mount that antibody response even with the second vaccine. Mainly people who are immunocompromised. So that risk is a little bit there with vaccine breakthrough infections. But even then, even if you have a breakthrough infection in them, the infection is very, very mild. So now coming back to your question about when to check antibodies, we do not check antibody response post-vaccination, not recommended. And again, quantitative antibodies, we don't know how much is actually protective. And what is good for to say that at this point you are really safe versus not. So not recommended to check antibodies.
So in an immunocompromised host, you still give the vaccine in all immunocompromised?
Yes, no contraindication.
Okay. And what about suppose somebody has taken one vaccine and then develop first shot they taken and then they develop COVID and then they recovered. So how long after the second dose to be taken, or they need not take at all?
Now more and more data about vaccines is evolving. Whether one is enough, two is enough. But if you have to take it, if the study has been done with 2 vaccines, you should take the 2 vaccines or 2 doses. Typically, somebody getting COVID after their first shot, they're saying 10 days, when their symptoms, after 10 days, they should be out of that isolation period. So after 10 days, when their symptoms are better, they should be without fever for 48 hours. After that, they're eligible to get the second dose. In my personal opinion, I tell my patients to wait for 4 weeks, only because people who've had COVID, when they take the second shot, their reactogenicity, this is again a subjective advice that I give. Subjectively, I have seen that their reactogenicity is much higher. Somebody who's had COVID and goes for a shot at day 10 or day 12, they have a lot of arm pain, fever, all the reactogenicity symptoms are much enhanced. So I tell them to wait about 4 weeks. But anytime after the 10 days and fever free for 48 hours, they are eligible to get the second shot.
Okay. Raj, you were talking very much elaborately on oxygen. It's like revising my physiology. It was wonderful, wonderful, Raj. And you gave a real anecdotes and, Hindu mythology, Bhagavad Gita and all that. Very impressive. Now I'll ask you one question. The oxygen concentrators are now being imported or being given by many agencies, where we can use oxygen concentrator. If I have a 5-liter oxygen concentrator, in which type of COVID patients we can use and how do we use it?
Well, typically oxygen concentrators, they need a power source, continuous power source.
Raj, but your voice is breaking.
Oh, sorry. Can you hear me now?
Yeah, I can hear you. Yes.
Yeah, sorry. So they need a continuous oxygen source, a power source for the.
By the way, Raj, your wife is with you because you are talking very slowly.
Room.
Oh, so then you can talk freely. Why you are hesitating? This is on the other room only. Please go ahead.
No. Typically, if they're hypoxic, saturation is less than 94%. So it can be conservative or it can be more liberal model. In the conservative model, they recommend keeping saturations above 92%. But in the liberal model, they have actually recommended if the patient is younger, less than 50 years of age, doing okay, not too short of breath, you can keep the saturations above 90%. So typically, I give it's not, if you want to use oxygen, I would recommend using low flow concentrator, which is portable. So typically, you can use with a regular nasal cannula. If they can wear a mask, along with that, they can conserve more oxygen. Or if they're mouth breathers, or you can use a mask, a simple Hudson mask. Now, if the oxygen needs are higher, they're more short of breath, then you might need to use a non-rebreather mask with a reservoir bag. I don't know if the oxygen pendant or oxidizer, that mustache thing is available there, but that's something which I recommend for patients to conserve the oxygen. So in anybody with moderate disease or hypoxic, I recommend using oxygen concentrator. Oxygen tanks only last for a short period of time. They're only good for transportation. They, going by ambulance or something else, they last for 3 hours or so, unless they have liquid oxygen supply, which is hard to have at home. So oxygen concentrators is a way to go forward.
But oxygen concentrator is the only now available in many places. So how best to optimize these use? That's what you said. You can use mask and you can reduce the wastage. And then that's the only thing, because till at least we get an admission in a bigger hospital where oxygen is there. Can we use this as a intermediate, or vice versa? After being there in the hospital, when the PO2 comes to 90, they discharge home and then they say continue our oxygen in the oxygenator. Is it okay if we do that?
Yeah, that's excellent idea to do that. I also recommend proning. If they can prone at home, self-prone at home, or laying on the side, laying on their back, abdomen, that also can improve their oxygenation quite a bit. So
your point really good. In a home isolated patient with mild disease, proning by self-proning and then using the oxygen concentrator plus the mask, the Ravana Misai type catheter should be good and should conserve more oxygen, and it is very good also. Okay, what about when you use steroids? Is there any oxygen steroid and oxygen relations?
Yes, the recovery trial actually looked at. So they looked at patients who were not on oxygen and given steroids. They did not have, their outcome did not change. They still had this mild disease. So only for moderate disease, severe disease, if they're hypoxic, the recovery trial recommends giving dexamethasone, 6 milligrams once a day for 10 days. That was the trial. You can also use prednisolone. You can use methylprednisolone. But what was studied was dexamethasone. And that using dexamethasone has shown the decrease the need for oxygen if they're already on oxygen. So they did not require intubation, mechanical ventilation in that population of patients if used earlier on.
Okay, your voice still not clear.
Oh, sorry. So recovery trial recommends using dexamethasone, 6 milligrams once a day for 10 days, and that prevents the need for escalation in oxygen requirements and the need for intubation and mechanical ventilation.
So even in a normal patient who is in the hospital with moderate problem, it's always better to use mask or that particular, that Ravana Misa type thing instead of you doing this one. And what about the humidifier solution? They have a lot of, WhatsApp now. The humidifier solution should be pure, otherwise you get mucormycosis. And
so there's some data saying that some of the material in that the liquid can exacerbate inflammation in the lungs. So be sure you don't use tap water. You don't use distilled water or sterile water is recommended. You can also use, salbutamol, albuterol to mobilize the secretions. You can also use budesonide for mild disease that is shown in one trial to improve symptoms in patients and progression to respiratory failure.
Dr. Vijayan, you can ask some questions to Raj and Vidya.
Yeah, for everybody there. We've been seeing a lot of Bell's palsy in the wave 1 and also the wave 2. We've seen, is there any link? Have you noticed anything? Is there literature on that one? And 2, we've been seeing a lot of minor strokes in the sense that they all appear embolic. And most of these strokes, which I have a small collection, there are no comorbidities. They're not hypertensive, they're not diabetics, they don't use, they're not smokers, but still they develop strokes and they have a high level of antibody titers, but don't have any history of previous COVID illness. And I've been seeing a few after vaccine also. Of course, not related to thrombocytopenia, not related to low platelet count, just high levels of antibodies to spike protein. And they develop minor strokes, they all recover well. Have you noticed any of this sort of pattern there?
I can take that, and I would probably also ask Dr. Singh to comment on it because he was talking about anticoagulation. Remember the pathogenesis of COVID. You have the acute phase, you have the direct viral invasion and effects related to that, then the cytokine effect. And then after that 4 to 6 weeks, you're really in that post-COVID phase, and the thrombogenic potential for the virus and the illness is extremely high, 15 times as compared to baseline. So, yes, I think that's definitely something we look out for. And that's why we talk so much about whether or not you should proactively give anticoagulation versus not. So, strokes, yes. With your question regarding Bell's palsy, whether it's with COVID or whether it's with a vaccination, I will address the vaccination part, and I can defer to Dr. Singh to talk about the anticoagulation and the strokes and thrombogenic side effects of the sequelae of the illness. With the Bell's palsy and mRNA vaccines, that was one of the things that ACIP, the advisory Committee of Immunization Practices, one of the bodies of CDC, looks for when they are approving a vaccine. They looked at very carefully at Bell's palsy. There is no increased number or percentage of Bell's palsy as compared to baseline. So this was a concern. This did come up. They actually looked at it proactively in their phase 3. And now we'll know more with phase 4 as the data is being collected. CDC is really proactively looking for side effects and reporting. Patients also have an app. If they have any side effects or how they feel after the vaccine, they can actually enter and give data and feedback through that too. So we'll see if there's anything coming out of that. But from phase 3, what they looked at, there's no increased risk of Bell's palsy or any neurologic side effects from the vaccine as compared to baseline. Dr. Singh?
Yeah, Dr. Vidya, thank you. So, COVID is a highly thrombogenic strain, and I feel that the kind of reports we're getting from India seem like the Indian variant is super thrombogenic, as I call it, because I've heard of several anecdotes where people are collapsing and all that. So mostly the we have seen are basically pulmonary emboli or even myocardial infarction. I'm not aware of much of stroke patients, but yes, maybe they are silent strokes and all that. And if you really go,
okay,
just minor strokes. Yes.
Yeah. Please
Hello?
Go ahead.
Yes. So the other one is, I think maybe Dr. Vidya can allude to that more about the risk of cortical venous thrombosis with the Johnson & Johnson vaccine. And I had a patient recently who had received the vaccine, and there was some concern about cortical venous thrombosis with that. So that particular vaccine was kind of removed recently and has been reintroduced. But I think maybe Dr. Sundaresan can tell more about Johnson & Johnson vaccine.
I want to clarify. I mean, even with AstraZeneca or the Johnson & Johnson that they looked at here in the United States available, and they looked at the number of, thrombosis in large vessels like the splanchnic vein or cerebral sinus thrombosis was actually not very high, 6 in 6 million. So it's a very small number. But even that was hard enough, was actually enough for them to look at this a little bit more closely, pause the whole vaccine campaign there, look at it again, look at the data, and they said, okay, it's fine, it's not that bad. The reason they also did that was the way these thrombosis phenomena are occurring. You look at it, it's a little different from DIC. The bleeding potential with DIC was not seen in acute illness, but when they're seeing this as a complication of vaccine, there was some bleeding potential along with the thrombosis that they were seeing. So they wanted the physicians who were taking care of this to have a little bit more guidance, and that was also the reason for the pause. But because the numbers are so low, and the causality, they're still investigating as to whether or not it's related to the vaccine. That's still being studied. But as of now, the vaccine has been reintroduced. The pause has been lifted.
Okay, now I'll come to Raj, because this oxygen concentrator is the now talk of the town, and they are all procuring. One of the persons asking, Adit Bajpai, my grandfather is 90 years, tested positive on 16th April. He was recovering well. On April 13th, his oxygen dropped to 80, and we immediately connected to an oxygen concentrator. The concentrator is able to provide only oxygen 2.5 liters per minute. 2 days ago, he tested negative, but his SpO2 is still around 90 for about 20 minutes when he is off the machine. It drops further to 85 within the next 15 minutes. With support, it maintained to 93, 97. Please guide, Raj.
Yeah, so I think it's a very good question. I mean, the virus may be negative, but the effects of cytokine-induced damage can persist for weeks to months. So I've had patients who had COVID back in April who survived, and they are still, having symptoms now. They're still on oxygen, and COVID can be negative, but the effects will persist. So that's one thing. So just be aware of that. So he may need oxygen via concentrator. If to at least 3 liters per minute. If it's still low 90s, I would go up to like 3 liters per minute. He might, I recommend doing deep breathing, self-proning still. You can also use instant spirometry and the flutter valve to help mobilize the secretions. So he has to be in oxygen continuously. I don't want him to go off the oxygen because as you know, when he's sitting, he's fine, but each time we move, we consume more oxygen. So our body consumes more oxygen. So these patients may need oxygen for up to 6 weeks to 12 weeks after they recover from COVID. So
and Raj, you are mentioning in the chat box that if you change the mask, it will be good. Please explain why you say that.
So you can also change. So nasal cannula is, again, when you're using a nasal cannula, remember you also are breathing through your mouth, so which dilutes the oxygen. So you can also use a mask to help them breathe if they cannot go to a different concentrator. You can use like a headset mask.
Yeah, how long after every time you have to change the mask?
I mean, like a new mask, you mean?
Yeah.
So that mask typically lasts for 2 weeks. It has to be cleaned very well with a antibiotic solution. So this is made of plastic, so it should last for at least 2 to 3 weeks without any problem.
And one Amritraj, he said, my mother is okay, and she was discharged, and a CT test shows 50% lung involvement, and she is okay, negative. So how long and what treatment you should give? Anything for post-fibrosis prevention for that case?
It's an excellent question. I tried to answer it on the chat box. So the problem is, sometimes the lung score can be very high when they come in, but that does not mean all of them end up with pulmonary fibrosis. So there's no really correlation between chronic disease. So I've had patients who have mild disease initially, but after 3 months, if you do a CAT scan, they have severe fibrosis. So unfortunately, we don't know how this COVID score really pans out in the future. But coming to that, to the patients, to the doctor's mother, as long as she's doing well clinically, I would still self-monitor her symptoms, checking pulse oximetry every day, making sure that she's not short of breath, making sure she's doing deep breathing, lung exercises, walking. I would do that. Now, if she still has symptoms beyond 6 weeks, she'll need a full pulmonary function test. with diffusion capacity measurements, as well as repeating the CT scan of the chest to be sure there's no fibrosis. There's really no data to use anti-fibrotic therapy like nintedanib or using pirfenidone yet. There is a trial going on in Italy and Spain right now looking at the use of anti-fibrotic therapy in these patients. But so far, we don't have any data. Right now, I recommend not using it until we have evidence-based, recommendations.
Okay, now, Vidya, we have got so many questions. Now we'll go for a rapid fire round. What is the significance of CRP? Is the CRP is helpful to start the steroids or heparin, or D-dimer is important, or interleukin is important in the lab test?
Well, it's a combination. If these numbers are high, like I was mentioning for tocilizumab, 75 is a cutoff for CRP. D-dimer, actually, I would defer that to our ICU colleagues or the hospitalist team to see if a therapeutic anticoagulation needs to be started. But they look more so for the evidence of PE, pulmonary embolism, or DVT for therapeutic anticoagulation. But I would defer that to them. But what we do is infectious diseases services is we look for all these markers: lactate, D-dimer, CRP, sometimes even ESR, ferritin. Ferritin is very important, and we track them, and white count. You see leukopenia, and as the leukopenia actually starts to get better, patients are getting better. So it's just serially tracking these and to make sure that they're moving in the right direction. Tracking these serially can help to identify if the patient's going to take a turn for the worse and preemptively do something with that. I'll also have Dr. Singh or Dr. Sridhar comment on that.
Yeah, I rely mainly on the clinical findings, but definitely it gives me the direction. So if I have high index of suspicion for pulmonary embolism, I will go for imaging in these patients. But again, clinical correlation with the markers is very, very important.
Okay. Please answer this question also. When do you give anticoagulants and what type of anticoagulants do you give apart from low molecular weight heparin? Do you use NOAC, aspirin, and clopidogrel? And if you so, how long?
Yeah. Are you talking about routine use or
routine in the patient, COVID patients?
Yeah. So routinely, I've been using the DVT prophylaxis with either enoxaparin or heparin in the usual dose of 40 milligram sub-Q once daily. If somebody has a BMI of more than 35, I've been using 40 milligram sub-Q BID dosing. If they're obese. Otherwise, we don't routinely use aspirin or clopidogrel. And you can use the NOACs like Eliquis also for DVT prophylaxis.
No, but only for DVT prophylaxis. Is there anything for a specific, in the COVID after discharge? Are you advising them to continue for 6 weeks or something like that?
No, we are not routinely recommending unless they had a proven DVT or pulmonary embolism.
Okay. Then Vidya, what about herd immunity? See, after how many people getting vaccinated, they get herd immunity?
So, Doctor, herd immunity is a concept where, at least 75%, we're saying 70, that number keeps going up. Now people are saying even 80. So anywhere from 70 to 80%, you say that of the population has antibodies or is protected. And this could be from natural infection or vaccination. But in an effort to try to increase that number, you want to proactively vaccinate. So you want at least 70% of the population vaccinated. Also to remember that children under 12, now Pfizer is actually looking for their approval, FDA approval for 12 to 15. And most likely next week we'll have that here as well. So 12 and above, if you're able to vaccinate, try to get as many people vaccinated as possible. Despite the natural infection will give antibodies for about 3 to 6 months. Vaccines are much longer. So vaccine antibodies are definitely better. Vaccinate despite natural infection, and you want to get as many people vaccinated as possible, 60 to 70%. That's good herd immunity.
Suppose somebody has taken Covaxin first dose. Wrongly, they are taking Covishield after second dose. Is there any problem for it?
Typically you don't want to mix. That has come up quite a bit. Let's say somebody has had an allergic reaction. Can they take another vaccine of a different type, you want to try to give them the same type. If there's an allergic reaction, then probably consider something else. But what we are doing is, somebody got Moderna and got Pfizer for the second dose. We are just monitoring that. We are reporting that to CDC. We just monitor them, ask them to call us back if they have any symptoms. Just monitoring and the reassurance is important. Otherwise, the antibody response may not be, instead of 90%, they may develop a 80% antibody response. So we can't say. But ideally, you want to try to avoid that mistake as much as possible.
Okay, some really enthusiastic people are asking. I had got to first vaccine, second vaccine, Covishield finished. Can I have Sputnik vaccine after 6 months as a booster dose? Yeah, because Sputnik and the Covishield are somewhat similar.
So I'll take this question because this is a really interesting concept, which is actually coming up quite a bit. CDC is addressing this. They actually published a very nice, a conglomerate of all these questions with regards to whether you can mix vaccines, whether you can take a different vaccine. So let's say somebody from India who's already received Covishield or Covaxin is coming to the US. That is not approved in the US. Do I have to take J&J again? We get these questions quite a lot. I've taken Sinopharm in Dubai. I'm coming to United States. Sinopharm is only 60% effective or 70% effective. Do I need to take something else which will get me up to 90%? We typically tell them, no, it's okay. Whatever antibody response they've gotten is good enough. But at the end of the year, there's going to be a lot more data with prospective studies with regards to how long these antibodies are lasting, whether or not a booster is required. So at the end of the year, I would say, look for that data, look for all those studies coming up, and we'll have a lot more comfort with giving booster doses if they are necessary. But as of now, whatever is the available vaccine is the best vaccine. I'll say that again. The available vaccine is the best vaccine.
Well, that's very good. And what about, say, my friend Padmanabhan asked that vaccine, booster dose question. What about how do we prevent third wave? If at all you think a third wave also is going to come, how do we prevent it?
I think what is happening epidemiologically in the United States is a good example of how effective vaccines are. You want to have a good balance between the non-pharmacological measures as well as the pharmacological measures. You want to take good care of the patients. Of course, you want to avert the crisis, but at the same time, to really avoid that curve from surging or flattening the curve, vaccination is the way. And also to adhere to the mitigation strategies, wearing a mask, trying to be as adherent as possible, wearing a mask, cognizant of washing your hands, good practices like that, watching distance. All these things are really helpful as much as possible. And then robust vaccination efforts simultaneously occurring, you can hit that plateau and flatten that curve effectively.
I think Raj is very good, He has already answered many questions in the chat box. I cannot repeat those questions. Maybe people who have asked the question, they have got the answer. And he had also given at least 5 consultation. I will get the consultation fee from them and give it to you, Raj, because they're individually they've asked a lot of questions from you, and you are kind enough to answer the questions. I think I will ask Dr. Rajshekhar, one of the panelists there, to ask one question. Rajshekhar, are you there, please? Rajshekhar? Rajshekhar? Okay. I don't know. He's not there. Please unmute and speak, Rajshekhar.
Yes. So there is a question on ischemic stroke and microthrombi. There is a relation of microthrombi enriched in fibrin and complement C5b to 9. So that is why the myocardial necrosis and also to some extent the ischemic stroke. That's why even occult, because of this occult microthrombi, the patient's sudden death. And I want to highlight on this, what's your assessment of SCARP, SCARP, that is the severity of COVID-19, that is adaptive risk predictor, that is being developed by Johns Hopkins University, that is released recently in Annals of Internal Medicine. What's your comment, Dr. Rajagopal Sridhar?
I've not even, sorry, can you hear me?
It's a very recent article.
Yeah, so
I'm going to release
one
it.
of the prediction models available. There's so many of them available. WHO has their own model.
Yeah.
Johns Hopkins has started this new model. So really, it's very good to have all these models, but I like something which is more simple. It has to be more validated. It has to be working for people at the bedside. I mean, it should be like junior doctors should be able to evaluate this. Nurses should be educated to evaluate such patients. So education is very, very important and crucial. So making that, I looked at the tool that looks pretty complex to me. So I don't know how easy it is to deploy such tools at the bedside when you're seeing a patient in the hospital and emergency room. It can be done maybe at higher centers with experts and things like that. But I feel should we have something which is more simplified, it will be more useful. And plus, it is not yet fully validated. You rather use a WHO model right now instead of going to something new. So I would give it some more time to work and show it is a good tool to evaluate such patients. So I would just hold off before rushing to use such newer models until it is well validated.
Okay. Vidya, what about steam inhalation? Routinely, people take steam inhalation.
Steam inhalation.
Yes.
So, doctor, I got asked this multiple times. If you get symptomatic relief from that, I don't see any harm. But with COVID, there is so much of inflammation everywhere. So I would not be very aggressive. If there is symptomatic relief with anything, that's probably okay. Do not overdo anything. Nebulizers are actually not recommended. Anything that irritates the airways, not recommended. Dr. Sridhar, do you want to comment on that too?
Also,
but I think,
Sridhar, you also comment. Can the steam inhalation can be used as a prophylactic method? Because somebody religiously day in and day out they use steam inhalation, thinking that if there is any virus, the hot air will kill the virus. Your opinion, Raj? Unmute and talk, please. Please unmute.
You're muted.
Sorry. So I get this question asked by all patients. Every day I see patients ask me, how does steam inhalation help? Unfortunately, it does not. As the steam enters our nose, our nasal mucosa, our oral mucosa actually converts that steam into regular temperature. So you're not getting that. So it still will be 37 or 38 degrees Celsius. So our nasal mucosa kind of auto-regulates the temperature and the humidity. So really, it's only it doesn't even reach your lungs. So it's not really effective. It's not shown to be effective. So what steam does do is improves the nasal congestion if they have that. So in people who are on chronic oxygen therapy, they have dry nose, they have some bleeding from the nose, it will help in those patients. But it does not prevent COVID. It does not, So I tell people sometimes you could be doing more harm than good. So let's say you inhale the steam too deeply, you can cause inhalational injury. You can, I've had patients in the US who have had, inhaling all this. There's a special device here, and they've had burns in their nose and their throat because of that. So I tell patients not to do that. It has been shown to be ineffective.
Yeah. Vidya, about the anticoagulants orally, the steroid inhalation by sprays, can we use that in the home quarantine? So what is the protocol for home quarantine for mild cases? Prophylactically, can we use steroid inhalation? Can we take oral anticoagulants also as long as we have the quarantine period?
Yeah, again, doctor, I'm going to comment from the Infectious Diseases Society guidelines. For mild disease, the use of steroids is really not much. So inhaled steroids or oral steroids, actually more so studied with oral steroids, that there's really not much value of that. We have seen people who are managed at home after they're done with the acute phase of the illness. They have a lingering cough, they have bronchoconstriction. In those situations, we do give steroids, we do give albuterol to patients in those situations, but otherwise prophylactically there's not much role. Dr. Singh, do you want to comment on that? That's really your area too.
Didar Singh ji, you unmute. Yeah.
So, I mean, there's not much role in the quarantine setting with for steroids in the mild disease. And again, speaking for the oral anticoagulants, I think we may have more bleeding risk than any protection. So, not routinely recommended. This is based on our experience here, but I think the kind of reports we're getting from India, I think the thrombogenic risk is very high. So I really don't know what the recommendation would be later on in the retrospect. But at this point, no routine use of oral anticoagulants in quarantine setting.
Okay. What about doxycycline or any antibiotic role, Vidya? Is there any role for doxycycline and antibiotic in this situation? When somebody has got respiratory infection, we don't know whether it's COVID or not. They want to consult, teleconsultation. They used to give erythrocin, azithromycin, and doxycycline, ivermectin. You said ivermectin, it's not studied, not proved. What about doxycycline?
Yes, doctor. Actually, as a infectious diseases specialist, we are here in very, very particular about something called antibiotic stewardship. So we do not want to unnecessarily use antibiotics when not needed. COVID is a different situation. This is a different situation when at home. If you're concerned about a secondary bacterial infection, doxycycline is what we are using because it has some kind of a immunological benefit. They have reported some kind of an immunological benefit with doxycycline as well. However, if you're really trying to cover for the regular sinus organisms like Streptococcus, Haemophilus, and Moraxella, those are not really covered that well with doxycycline. Streptococcus is not covered well with doxycycline. So, augmentin or, any third generation oral cephalosporin, those can be some of the things. If you really want to give good coverage for Streptococcus, levofloxacin, quinolones, they can be chosen too. So really depends on a clinical judgment there. Talk to the patient, see if there are any concerns for a superinfection, productive cough, is the fever still lingering, sinus pain. So I think those really play into the choice of the antibiotic. Doxycycline given for a short course, even if you choose to give prophylactically or you choose to start up front, you don't know. A lot of times it's very hard to make those decisions when you're talking to a patient. You don't even see them. Sometimes it's just a phone call and you need to make these decisions and you want to use an antibiotic. Doxycycline or azithromycin would be something that I would recommend. Keep the course short. You want to keep it at 5 days to 7 days. Shorter courses are recommended, and those would be the choices.
And what is your take on immunoboosters, vitamin D, zinc? Do you give routinely for all? Because now religiously we are all taking zinc and vitamin D. You think it's useful? Are immunoboosters?
So, there is, of course, data with vitamin C, zinc as, for the immune system. But specifically for COVID, this was studied. Annals reported this last month in March. No benefit from vitamin C, zinc, or vitamin D that they noticed for COVID and the outcomes.
Okay. So I think, Rashid, you want to ask something? Yes, please, Rashid.
What's the role of bibarotopic nano-antibodies? A very recent article study by Dr. Ram Sasishekaran that is being published in New England Journal of Medicine. What's your comment on that? Bibarotopic nano-antibodies, that's a future for COVID-19. What's your comment?
Yeah, doctor. I think, the nano antibodies and any of the monoclonal, you have to take that data with a pinch of salt. I think prospectively, whatever data comes out, we have to follow that very, very carefully. There is definite, this is the future, even with infectious diseases. This is really something we're all excited about because beyond antibiotics, at some point, antibiotics, antivirals are not that effective anymore. So, these the newer technologies, bacteriophages, those are some of the upcoming things. But more so for bacterial infections, viral infections, I think, these newer things as they come up, we have to see how they do prospectively before they become, something that we use routinely.
Okay, I think I am delaying your hospital work. So I promise I will leave you by 7, 2 hours. But I've taken...
Thank you.
We leave you.
Thank you. Thank you.
The BAM and ET and the tocilizumab monoclonal antibodies all are with you. So
We
you are,
do.
having, good ET. We don't have the monoclonal antibody. We don't have the tocilizumab. So you think by importing those drugs, or if we can get those drugs, it will be more beneficial for treating the patients?
Absolutely, doctor. I really think that's going to help a lot. And I think Regeneron just got approved to go to India. So you'll probably have that available. And I would recommend giving that in older patients, 65 and over, 55 and over with comorbidities. Those patients, definitely we see benefits to keep them in the hospital.
I asked this question purposely because you have been giving a lot of help to India by giving oxygen concentrator and so many things. So the next phase, if that is export is available, acceptable, give us some drugs also, which we can use it for selected patients, which would be good, because the monoclonal antibodies are doing good work, really good thing in COVID. So we'll be happy to have those drugs also. So with this, I think I will ask Rajshekhar to give one message and Vijayan one message, then we'll conclude. Rajshekhar, your views, one message, drive home message.
Yes, sir. See, COVID-19 pandemic is giving a great problem. Nobody knows what to do and how to proceed. Whether we have to go forward or backward, or to turn to the right or turn to the left. Every day it is changing. So we are almost in a gist of confusion. So thank you very much, all the speakers, for highlighting how to deal with COVID-19. So to some extent, it has cleared all our doubts. Thank you.
So thanks for confusion clearing. Then next, Vijayan, are you there to say?
Yes, sir.
Yeah,
thank you very much. The only thing, bottom line is vaccinate vigorously. That's it.
Vaccinate vigorously. That's a very good VV. Good. And final comment from our Didarji.
Unmute.
Unmute and speak one drive home message for all our viewers. Your message.
I will say COVID is a disease which is bringing out whatever ugliness we have as humans. So we have to fight that ugliness by being the best of us. So we have to bring that forward. That's what I would say. Besides being medical professionals, I think that's my message.
Thank you very much, Dr. Raj Sridhar. Your message as a pulmonologist.
I just want to say, namaskaram to all of you, and thank you so much for what you're doing. You're doing, such hard work and working so hard. I bow down to all of you working under such difficult conditions and circumstances in a resource poor area. So we are lucky and blessed to be here with all the resources available. But credit should go to you, for all of you, for working so hard in such difficult conditions. So really, I want to thank all of you. And all of you, please stay safe and take care of yourself and protect yourself, because you are very important, to not only to the work, not only to your patients, but your family and your loved ones. So please look after yourself, and thank you so much.
Thank you. Vidya, your final word, Vidya.
First of all, again, thank you so much for having us here. This is a great opportunity for us to be able to talk and interact with the group there. So thank you again, Dr. Muruganathan, for this opportunity, and the group for such excellent questions. I know you're right there, ground zero, frontline right now. I read yesterday, this was an unknown quote from somebody anonymous. It says, tough times do not last, but tough people do. So yes, I think it just goes to prove how tough our group there is, our frontline workers, our frontline staff, our physicians, our healthcare workers, how tough mentally they are, and it just goes to prove. So our support, our thoughts, our prayers are with you. Please stay safe. I would like to reiterate what Dr. Vijayan said. Vaccinate aggressively as much as you can. Please spread the message. Vaccines are really beneficial. They are able to change the curve. We have physically seen that, how the epidemiological curve changes with vaccination. We're seeing where the vaccination levels are high, you're able to avert a lot of bad things from happening. So definitely give that message out to your patients, and please carry forth that message. And public health strategies, these do work. So the 3 Ws: wear your mask, wash your hands, watch your distance, and with 1 V, vaccinate aggressively. So thank
So
you
you can,
very much.
yeah, yeah.
Yes,
So on behalf of all of us, I thank Vidya, Dr. Raj, Sridhar, and Didar Singh ji for having spent 2.5 hours early morning. You got up at 5 o'clock in the morning without even the filter coffee. You were there, talking to us and enlightening us. And not only that, friends, brothers, and sisters, Vidya is also organizing some fundraising from her side and sending so many gifts and helping hands for India. So thank you, Vidya, for that also, because she's really promoting fundraising and doing something, and oxygen concentrator, so many things she's doing. And then she also promised that in case if we require one more webinar, part 2, Vidya part 2 will be there in another 2 weeks. And she has given a lot of good points. And she, as Rajshekar said, he has they all cleared our conclusion. Vidya, for your matter, for your thing, I always say WW. You said, I always say follow women. Follow women. You know why follow women? W is wash your hands. O is observe distance. M is mask yourself. E is exercise and eat well. N is no, don't touch nose, no travel. So Sridhar is following always women, not women, but woman. But we also follow women. And you add one more thing. What Vijayan said: vaccine vigorously, not aggressively. Vaccine vigorously. With this conclusion and summary, once again, on behalf of all of us, you see, even now there are more than 130 to 140 people are remaining 2.5 hours. It was excellent. And I'm going to record, I already recorded, I'm going to put it in the website. And all the question answers Raj has given, many people have really, got the answers from Raj. So we'll put it. And any other question comes, I will ask you, and I can put it in email and then the WhatsApp group. We have got very good WhatsApp group. Believe me, we have got 7 WhatsApp groups where we always discuss all these things. Maybe I will include you in one of our WhatsApp group so that you can answer in a question comes also. With this, once again, on behalf of all of us, thank you very much. Stay safe. Good night. Take care.
Thank you, sir.
Thank you.
Dr. Rajagopal, I like your first slide, Sri Krishna to Arjuna. With your kind permission, I am going to project all your slides in our WhatsApp group. I have taken almost a snapshot everything. I am keeping it ready. Thank you. Whenever patients come for consultation, I never talk about the ailment. I talk only vaccination only. I arrange, in fact, vaccination for all the pharma friends representatives. I arrange even below 45 years. In our government, only now they are putting above 18 years. But last month, 2 months back itself, I arranged for vaccination for almost all the representatives. That is our important bind over. That is very important. So that is our social commitment. Thank you.
And Vidya, when you say 12-year-old girls and boys also can have vaccine, let us know. We'll start vaccinating also people, children between 12 to 18 years also. Okay.
Thank you.
Okay. Thank you very much. Good night. Good night. Good night. Sorry, you tell your chief that I only got delayed. I mean, I only delayed you. You are decent. Okay. Thank you. Okay. Bye. Thank you. Good night. Okay.
Yeah.